Does the outside of your elbow bite every time you grip or lift a kettle? It's called tennis elbow, but only about 1 in 10 people who get it actually play tennis. Around 1 to 2 in every 100 adults get it each year, and it's the most common cause of pain on the outer elbow. It usually strikes between the ages of 35 and 54, hits men and women about equally, and lands on your dominant, hardworking arm. The people who get it are painters, cooks, plumbers, hairdressers, office workers on a mouse all day, and new parents lifting a baby over and over. The common thread isn't a sport, it's repetitive gripping and wrist work. Here's the good news first, for most people it settles on its own. About 80 to 90% recover within 1 to 2 years, even with very little treatment, and it almost never leaves lasting damage to the arm. The catch is that it can be slow and stubborn. More than half of people still feel some pain at 12 months, and it can flare up again along the way, which is why it wears people down. So this isn't really about whether you'll get better, most of you will. It's about what you can actually do to speed it up, calm the flares, and stop it dragging on for months longer than it needs to. So what's actually going on inside your elbow? On the back of your forearm sit the muscles that cock your wrist and fingers back. They all funnel into one shared tendon that anchors onto the bony bump on the outside of your elbow, the lateral epicondyle. One muscle in particular, with the tongue twister name extensor carpi radialis brevis, takes most of the strain. And here's the key part, every time you grip something firmly, these same muscles tense to steady your wrist, so all of that pull concentrates on one small anchor point. Grip hard enough, often enough, and that's where it starts to complain. Overuse makes tiny tears in that tendon faster than your body can repair them, so it never heals properly. Under a microscope the fibers look disorganized and weak, a worn-out, frayed rope rather than a clean one. And here's the surprise, this is not classic inflammation. True inflammatory cells show up in under 3% of cases. That's why the old name epicondylitis, with its itis meaning inflammation, is really a misnomer. It's a degenerative tendon, not a swollen one. And it's exactly why anti-inflammatory quick fixes disappoint, the tendon just needs loading to rebuild. So what actually works? The best treatment is free, done at home. First, make sure it's really this. The pain sits right on that outer bony bump and the tendon just below it, and it's usually tender when you press on it. It flares when you grip, twist a doorknob, wring out a cloth, pour a kettle, use a screwdriver, or shake hands, and it can ache down the top of the forearm too. Many people feel it stiff first thing in the morning, and worse the day after they've overdone it. The sore side's grip strength can drop to about half your normal side, so even holding a coffee cup, turning a key, or using a mouse feels weak and unreliable. One reassuring sign to check for: plain tennis elbow doesn't cause numbness or pins and needles. If you do get those, it may be a nerve rather than the tendon, and that's worth a proper check. Do you need a scan to confirm it? Usually no. A clinician presses right on that outer bump to find the tender spot, then tests it against resistance. In Cousin's test, you make a fist and cock your wrist back while they push down. If that reproduces your pain, it's a strong clue. Mills' test stretches the tendon instead, and resisting your middle finger as you straighten it points to the same culprit. Cousin's alone reproduces the pain in about 91% of true cases. Between that tender spot and a couple of resisted movement tests, the diagnosis is usually made right there in the room, no imaging required. And don't be misled by scans. Worn tendons show up on ultrasound in plenty of people with no pain at all, and a normal scan doesn't rule tennis elbow out. When is a scan actually useful? Only when the picture is unclear, something doesn't add up, or the pain just won't improve. Then ultrasound usually comes first. It's quick, cheap, and can show the tendon thickened or torn. MRI is kept for stubborn cases or when surgery is on the table, because it shows the tendon and nearby structures in more detail. A plain X-ray doesn't show the tendon at all, it's only used to rule out other things, like arthritis or a fleck of calcium. But remember, imaging findings often don't match how much it hurts, so for a routine, textbook tennis elbow, a scan usually changes nothing about your treatment. Here's the one that helps most, and you do it at home: eccentric wrist extensor loading. Rest your forearm on a table, palm facing down, with your hand and wrist hanging over the edge, holding a light weight or a resistance bar. Use your other hand to lift the wrist all the way up, then let go and slowly lower it back down over 3 to 4 seconds under its own control. Only the lowering is loaded, and that slow, controlled lowering is the active ingredient that drives the healing. Do 3 sets of 10 to 15 once a day, for at least 6 weeks. Work into a discomfort you find acceptable. A mild 3 or 4 out of 10 that settles within a day is completely fine, and doesn't mean you're doing harm. And as it gradually gets easier, add a little more weight to keep challenging the tendon. Ease off only if it flares up badly the next day. It feels almost too simple, but that slow, controlled loading is exactly what nudges the tendon to lay down stronger, better organized fibers. It costs nothing, you're in control of it, and it's the reason you can genuinely get better without living at a clinic. Set your expectations right, though. The first couple of weeks may feel much the same, or a little sore, and the real gains from your 3 sets of 10 to 15 usually build from around 6 to 12 weeks. Don't stop the moment it eases, that's when the rebuilding is happening. And back it up by easing the load in daily life, lighten your grip, take breaks from repetitive tasks, and keep your wrist in a neutral, comfortable position. Give it a real 6-week run before you judge whether it's working. What about a brace, or dry needling? Think of these as boosters on top of the exercise, not replacements for it. A counterforce strap wraps around the top of the forearm, just below the elbow, and spreads the pull away from that sore anchor point, handy to take the edge off while you grip or load, though you don't need to wear it all day. Dry needling, where a fine needle is worked into the tendon over a short course of sessions, added to exercise lowered pain by about 2.1 more points than exercise alone. Hands-on physiotherapy, manual therapy combined with exercise is another solid, evidence-backed combination. Kinesiology tape and acupuncture, on the other hand, have shaky or modest evidence at best. So use the ones that help you as support for the plan, not as the plan itself. Some are genuinely useful add-ons, but none of these cure it on their own. The loading is still doing the real work. Now the injection everyone asks about, the steroid shot. A corticosteroid injected near that sore tendon origin does ease pain fast, often within days, and it can feel like a miracle for a few weeks. But here's the catch: the studies keep showing, by 6 to 12 months it actually does worse than doing nothing or than physiotherapy, with more pain and clearly more recurrences. Part of the reason is that it dampens the pain without healing the tendon, so you go back to overusing it too soon, and the steroid itself may weaken the tissue. So it's short-term relief bought at a long-term cost. That's exactly why it isn't your first move, and if it's ever used, it's as a one-off to get you over a bad patch, not a plan. Then there's PRP and shockwave, which get a lot of hype. PRP means drawing your own blood, spinning it down to concentrate the platelets, and injecting that back into the tendon, hoping the growth factors kickstart healing. Shockwave therapy pulses acoustic energy into the sore spot over several sessions. Both sound clever, and both have their fans, but the honest evidence is underwhelming. In the best placebo-controlled trials, PRP came out only 0.16 points better than a dummy injection at 3 months. That's a difference you simply would not feel, no matter how good it sounds on paper. They also cost real money and often aren't covered by insurance. So keep these in reserve for genuinely stubborn cases, and if you do decide to try them, go in with realistic expectations rather than the big promises you'll read online. And surgery? It's genuinely a last resort. Only a small minority, around 2% of people, ever have it. The operation cleans out or releases the worn part of the tendon at its origin, and recovery still takes weeks to months of rehab afterwards, so it's not a quick shortcut. The humbling part is what happens when it's tested properly. Head-to-head, surgery was no better than a sham operation, where they only pretend to operate, and no better than physiotherapy. In other words, much of the benefit people feel may come from time and rehab rather than the cutting itself. So it earns its place only after everything else, months of proper loading and the sensible add-ons, has truly been given a fair go and still failed. So here's your plan, in order. Start with the home eccentric exercise, 3 sets of 10 to 15, once a day, for 6 weeks and ease the load in daily life while you do it. Add a counterforce brace or dry needling if you need a boost, or hands-on physiotherapy. Keep steroid injections, PRP, shockwave and surgery in reserve for stubborn cases, going in with the honest numbers rather than the hype. Give the exercise a fair 6 to 12 weeks, and if you're truly not improving, or the pain is severe, get reviewed. But the headline stays the same: most of you will be a lot better within a year. That's your evidence-based game plan for tennis elbow. This video is general information, not a substitute for seeing a clinician, so if your pain is severe, sudden, or not improving, get checked. If it helped, subscribe for more evidence-first health explainers.